Welcome to the DCRI Research Conference. We're pleased to have three speakers today, Cynthia Benet, Gerald Bloomfield, and Eric Velazquez. But I also understand one of our colleagues will be available, Nathan Thielman, for the question and answer session. Cynthia received her Bachelor's of Science degree in nursing from Thomas Jefferson, and then a master's degree in liberal studies with graduate certificate in health policy from Duke University. She became the program director for the Hubert Jurgen Global Health Institute shortly after its inception in 2005. Jerry Bloomfield has been at Duke for a few years now. Jerry performed his undergraduate work at Princeton University and then went to Hopkins, where he received his medical degree. And Jerry is now one of the residents in the Global Health program here at Duke University Medical Center. And you'll hear a little bit more about his travel and work that he's done in Kenya. Eric Velazquez is well known to all of you, I'm sure. He attended medical school at Albert Einstein in New York and completed his residency training in internal medicine and fellowship in cardiology here at Duke University Medical Center. He's a cardiologist and associate professor of medicine at Duke. So the topic today is one of great interest to all of us, and we're really pleased to have you here today. It's combating chronic cardiopulmonary disease in developing countries, an update from the Duke Kenya NHLBI Center of Excellence. And I believe, Eric, you will begin.
Thank you, Dr. Becker, and thanks everyone for being here today. And we're doing something a little different today. We're going to try to engage a team of people to describe some of the work we've been doing over the last few years, mostly because this is not the work of any one individual, and it can't be completed by any one individual. So I think combining Cynthia's perspective and my perspective with Jerry as an up-and-coming leader in this field is kind of a good strategy to kind of help everyone get a sense of what's been going on, and a lot's been going on. I'm going to spend a few minutes just kind of highlighting a few pieces of why this is important. Should Duke and the DCRI play an important role in leading the field of global cardiovascular health forward? We're going to focus on just a few words on just communicating to you the importance of chronic cardiovascular pulmonary disease as a major non-communicable disease in the developing world, and the impact it will have on economies as well as individuals for many decades to come. I think Cynthia is really going to play an important role in describing Duke's efforts as it relates to the Hubert Jurgen Center as well as the other components of the larger Duke mission and how we've gotten involved in Kenya and what we plan to do. I'm going to spend some time again then reviewing a really fun project that we had funded a few years ago that we're in the midst of working on with some partners in Kenya called the Asante Center of Excellence, and I think everyone in this room should be proud. I just want to, before I forget, just remind myself to thank Megan DeLillo and Brenda Mickley and everyone in Duke BD for all the help they gave us as we put forward this relatively challenging proposal submission and the fact that we got it funded. And then I think really I'd like to highlight Jerry at the end here and have him have a chance to spend 15 minutes or so reviewing what he's done as our field director at research at the Asante Center of Excellence over the last year. Jerry is a fellow in cardiovascular disease, finishing this year. Hopefully will join us on faculty shortly, and it's played a big role in the development of this project. Let's see how this works. So just to highlight a few points, chronic disease in developing countries are a gross business. The World Health Organization predicts that unless urgent action is taken, we're going to have about 64 million people who will die in 2015, and 41 million of those people will die of chronic diseases. 4 out of 5 deaths expected in 2015 will occur in low and middle income countries. And the burden that those diseases have in those countries are particularly great because of the fact that it affects people at a younger age group who are in the midst of their highest potential for earning, and the impact on families is immense. Of the diseases that we call chronic diseases in the developing world, about 60% of those total deaths will occur in what we call non-communicable chronic diseases. So traditionally, people have thought of the developing world as the place where communicable diseases or injuries are the leading cause of death. Well, that's changing, and you'll see some information to support that in a moment. And about 60% of the deaths, and particularly cardiovascular disease, is playing a larger and larger role. In terms of non-communicable chronic diseases, cardiovascular disease is preeminent. It's estimated in 2005 that it will lead to 17 million deaths in the world. And it falls disproportionately on all countries, but particularly in low and middle income countries, where 80% of all cardiovascular deaths are expected to occur in patients who have a per capita income of less than $9,000 a year. So put that in perspective in terms of your own economic situations and the impact of that on the family, if those individuals are the major breadwinners for those families. And in these countries, 45% of those deaths will occur in patients aged 70 or less. So this is some data that comes from the Global Burden of Disease assessments, and you can see that it doesn't matter developing country or developing countries, ischemic heart disease is still the #1 cause of mortality and morbidity. But you can see that in developing countries, you've got a lot of other players. I'm not sure if this is working. There it is. But anyway, you can see here HIV, diarrheal diseases, tuberculosis, malaria playing a larger part, where those don't exist really in developing countries. So you can imagine that as more and more attention has been turned to those diseases which are being treated, cured, what have you, the impact of ischemic heart disease in developing countries will become greater and greater, as it has in our own countries. This is a 10-year risk of cardiovascular deaths by the World Health Organization, and this is where in areas of the world where we expect greater than 25% of the 10-year risk to be related to cardiovascular disease. So a couple of key points. One is I want to highlight that the fact is that in Africa, which we're going to spend the rest of our time talking about, it's relatively limited impact right now. But if you look at other areas of the world, and there are people in this audience who are working a lot in India, in China, in so-called developing economies, the impact is greater already expected than what it is in North America and in Western Europe, and is only growing. And really, the epidemiological transition that has occurred already in Asia, we are on the cusp of in Africa. And the impact will be much greater because of the more limitation in resources. And so this is just you maybe have all heard of this concept of the epidemiological transitions as it relates to cardiovascular disease. And we are past the age of pestilence and famine in Africa. We are receding. The pandemics are receding. We are now at this point where most of the cardiovascular deaths are occurring in those patients 35 to 65 years of age. And as we do better and better with regards to the control of malaria and other diseases, the impact of cardiovascular disease in sub-Saharan Africa will increase as this transition continues. This is displayed in another way in this slide, and sorry it wasn't so blurred in my screen, but it looks pretty blurry here to me. You can see here in Europe and Central Asia to the left, the impact on the orange lines of chronic non-communicable diseases is far greater than communicable infectious diseases. And as you see across different economies and different levels of development, East Asia to Latin America to Middle East to South Asia, you see a transition zone where there's this balance between communicable and non-communicable is changing. And then in sub-Saharan Africa, obviously the impact of communicable, maternal, perinatal, and nutritional conditions on outcomes are much higher right now. But again, this is just a temporary stage, and we believe, and I think the data will support, that we have an opportunity to do really prevention, primordial prevention in these economies, in these countries, before they end up like Asia and the U.S. There's some dissonance, though, with regards to the funding that's available to support these emerging epidemics in chronic diseases and non-communicable diseases. And this is just data from the World Bank and from other sources, and just, I think, has become a calling card for many individuals working in this area of global cardiovascular disease. And you can see here, in terms of disability-adjusted life years on the bottom, and then the total disbursements in billions of dollars in aid. Most of the aid goes to those disease states which get, frankly, better press and have a more acute impact. Malaria, HIV, diarrheal illnesses, waterborne infections, and so much. But the impact on disability-adjusted life years is dissident related to the funding. So you see on the right, you have this little dot, non-communicable diseases, which really gets very little bit of the funding so far, but has a much greater impact on disability-adjusted life years. So just to before I turn it over to Cynthia, just a few other points. Predominance of CVD and other chronic diseases in the global burden disease is a new Millennium Development Goal. And you'll see funding opportunities, which we've already started taking advantage of, become available. And we should be in a position, I believe, at ECRI, at Duke, to do well, to gather some of those funds and support some of the important work that needs to be done. We know that the integration of these disease state models into clinical care is going to be a challenge in some of these locations. And I think we can apply some of our knowledge to that, and I think we're well positioned to meet that development goal as well. So we are, I think, really well positioned in terms of policy, in terms of research opportunities to really do well in this new and burgeoning area of funding. So I'm going to ask Cynthia to get up and talk a little bit about how Duke is already engaged globally and introduce the concept of our Center of Excellence. Cynthia.
Thanks, Eric. Am I on? Okay. I did want to address how Duke is engaged globally. Certainly it's become more fashionable in the last few years to be involved in global health, but I think one of the things I'd like to share with you is how Duke has been involved both on the individual level for many more years than you might be aware. And that leads us to the Hubert Jurgen Center for Global Health. One of the questions that I get asked all the time is, who are you and how are you different from the Duke Global Health Institute? So I want to just take a couple moments to share what our engagement has been globally, as well as in Eldoret, Kenya, which is the site for where we're doing our Center of Excellence. So I think both at the Hubert Jurgen Center and the DGHI, we like to think about our collaboration as being very synergistic. But one way to look at it also is that this is us and this is them. They're a much larger organization. They have a lot more financial wherewithal. But by the same token, we've been around for a much longer time. The origins of the Hubert Jurgen Center goes back to almost 25 years when Ralph Corey was sent to a small mission hospital in Kenya called Tenwick Hospital. And in the upper right-hand corner is a picture of the ward where he was sent for 3 months. And I think for any of you that have heard the story, it had a profound impact on his life. And it's what led to the ultimate creation of the Hubert Jurgen Center. When he was program director in the Department of Medicine, he had the opportunity to develop relationships and provide opportunities first in Tanzania to set up an educational exchange program, which originally was unidirectional, sending Duke residents overseas. But over the years, our emphasis has become much more on a bidirectional exchange. And so you'll see that Dr. Corey's got relationships all around the globe that have extended out for the Hubert Jurgen Center. To date, we've got over 400 residents, foreign trainees, medical students that have gone back and forth across the oceans for training. With all the numbers that we've been able to garner, this led to data that was first published in 1995 with Dr. Bill Miller at the UNC. And it showed the value of these educational experiences. And with the data came the opportunity to garner the attention of the chancellor, philanthropy, endowments, and eventually we were asked to go up to Harvard by Chancellor Zhao to take a look at what their global health residency training program was. We subsequently came back, and one of his charges to us was to not only develop a residency training program in the Department of Medicine, but that he wanted it to be opened up to any department across the medical center that was interested in participating. And so that started, I believe we got funding, Nathan Thielman's the program director of the Global Health Residency Program, and we got funded in 2007. Since then, we've had residents in emergency medicine, psychiatry, neurosurgery. We've also had some fellows. Jerry Bloomfield was in the program for cardiology as well as infectious disease. And many of these programs have taken place in Eldoret, Kenya. So if you just want a succinct way of looking at the difference between the Hubert Jurgens Center and the Duke Global Health Institute, the Hubert Jurgens Center origins are really in the long history of global health at Duke, and I think that's really important to remember. We eventually got philanthropic dollars in 2004, and that's when our center was officially created. The funding for the Duke Global Health Institute comes primarily from the Chancellor and the President for the initial startup funds, and certainly one of the things they're looking to do is bring in a lot of grants to bring in subsequent funding. The Hubert Jurgens Center focuses primarily on residency training programs, although we've certainly done things with medical students and undergraduates, whereas the DGHI has a much broader focus, primarily across campus as well as medical center. Both of us are interested in the research service and education mission, although the DGHI does focus on policy. But I think one of the areas where we collaborate most closely together is on the programmatic site development, because doing these things overseas takes an enormous amount of personnel and resources, and it just makes sense for us to be able to develop the platforms where we can do the work that we want to do overseas. So with that, I'm going to send it back to Eric.
So what I want to do for the next few minutes is really just talk about our Center of Excellence and kind of set things up to be able to share with you some of the challenges that we've had over the last year and a half and how we've worked through those challenges. So the most important concept, though, is that the NHLBI has developed a global health initiative, and has funding now available that we are tapping into to kind of lead some efforts. And I think it really has come at the right opportunity. It's the right opportunity at the right time for Duke, based on what Cynthia has told you about the different entities that exist on campus to really focus in this arena. So there's a broad agency announcement that was created in 2008 requesting innovative approaches between developed and developing countries. So the concept of twinning is one that I want to highlight right here. The twinning between a developed country and a developing country in terms of development of the grants as well as implementation of the research. And they want to fund research and training centers aimed at prevention and treatment of chronic diseases in developing countries. This is a busy slide. I'm going to read it because I think there's some value in just reading what they are trying to achieve. Okay, and I'm going to have to read it from the slide. The nature of this program is to combat non-communicable chronic cardiovascular pulmonary diseases in developing countries by enabling clinical research infrastructure development and research training, and by conducting research of new or improved approaches, programs, and measures to prevent or treat chronic CVPD. Does it sound like anything we're used to? It sounds exactly like the DCRI. The program objectives are to develop research centers of excellence with faculty and staff capable of conducting independent and or collaborative research, as well as training future investigators at the doctoral and postdoctoral levels. This program is expected to stimulate clinical, epidemiological, health services, and outcomes health policy, translational, and behavioral research. So it's a very broad initiative, and I think one that you'll see, I think we fit in nicely with. The contract mechanism was established, required that this work be done at an established Fogarty Center. So Ralph, I believe, and others and Nathan have established a Fogarty Center in Tanzania. The opportunity actually was better for us for this Center of Excellence to work with a group in Kenya, and that bridges the partnership we developed with the Brown Fogarty Center, of which Jerry was a fellow in last year. It has to have existence of research center capabilities, a mechanism for administrative guidance and financial oversight. These are not small things in a developing world, as you'll see in a moment. And we were fortunate enough to be funded on our submission, and with partners that really brought this twinning concept to the fore. Sylvester Camayo runs the AMPAS program, which you'll hear about soon, and I, as the principal investigators, were twinned by senior mentors, Ralph Corey and Bill Tierney, and someone who you'll see pictures of, but I think deserves a mention because he's someone that really has made a huge impact in this part of the world in his role of developing this Indiana University Kenya partnership with this guy's named Joseph Mamlin. And really, those three individuals said, hey, Duke wants to participate and wants to be active in helping our site in Kenya grow. And this is a great opportunity, and linking us together was really their idea, and I think Cynthia played an important role in that too. There are several centers that are funded through a combination of NHLBI funds, which is our mechanism, or United Health Network funds through the Global Alliance for Chronic Cardiovascular Diseases, or chronic diseases. And I just highlight the fact that we're fortunate at Duke because Mike Mercer and Eric Peterson, among others, are leading another center in China, which allows us to develop intra-institutional collaborations across multiple different locations. So you can see the scope of where these centers exist. And these centers are all led by a developed country PI and developing country PI, and meet as a steering committee on multiple occasions, as well as teleconferences monthly to kind of recap what's going on and how people are approaching pursuing the statement of work that was laid out. So ASANTI stands for American Sub-Saharan Africa Network for Training and Education. It is really a very interesting history. It started in '89, where Indiana University and Moore University teamed up to develop healthcare leaders, and there was a lot of exchanges going on. Moore University is in western Kenya, near, I guess, towards the Uganda border on the Great Rift Valley, and it is the second university in Kenya to have a school of medicine, named after the second president of Kenya, Daniel Arap Moi. In 1998, this consortium of academic partners in the U.S. formed together to help support Indiana University's initial efforts at Moi University, and because of what truly was a remarkable epidemic of HIV that strangled Africa in the late 90s, early 2000s, AMPAS was created in response to that as an independent body. So I talk a lot about AMPAS because to me it's still remarkable what AMPAS is. It stands for Academic Model Providing Access to Health Care. And it's a partnership between Moore University and the Moy Teaching and Referral Hospital. And it includes over 30 satellites, clinics. It has a budget of over $85 million over the next 5 years. It's enrolled over 100,000 HIV patients, of which 60,000 or greater are receiving care. And it's received funding substantially from across the globe. This is some pictures of where, this is on the equator, although the temperature is nice because it's kind of high. But this is a picture of the outside of the Moy Teaching and Referral Hospital. And other pictures you can see of, it's mostly dirt roads. But frankly, with what little they have, they do quite a bit in terms of care delivery. And just an example of the different clinics and different administrative offices they have. And some more pictures, really it doesn't look a whole lot like Duke, but it is able to give great care. And I think Jerry's going to go into some details about what it's like to deliver care and do research in that environment. So this is kind of the schemata of the geography. You see Lake Victoria on the left side of the field. You see Somalia towards the top. You see Uganda towards the left. So it's not in a great part of the world in terms of safety. I have some patients who always want me, who have some connections. So they always want me to tell them when I'm going because they can call some people they know in the State Department. But I never ask questions. But Doreen knows who they are. But you see, it's really a really remarkable network linked by an electronic medical record. Just put that in perspective. I mean, it's hard for us to have an electronic record in Durham. They have an electronic medical record that gathers information across 30 clinical satellite sites giving HIV care and antiretroviral therapy to a population catchment area of over 2 million people. This is what I mentioned, over 100,000 enrolled, 60,000 currently receiving care, about a third of those receiving antiretrovirals, 1.1 million visits a year, an electronic medical record with 34 million observations already recorded, and as it grew, the observation became apparent that they had to expand beyond HIV care to chronic diseases, and that's where we fit in. So I'm going to ask Cynthia to just speak a little bit to the history of how this was all created, this interrelationship.
Okay, again, getting back to Duke's involvement, I have to go back to Ralph Corey again, because his father-in-law, T.K. Lee, had connections to Indiana University, and he kept hounding us and telling us we had to go visit them and see what was being done in Kenya. And so around 2005, I made my first trip over there, and it was one of the most remarkable things I'd ever seen, and came back and just said some way or another we had to get engaged in this. So the Hubert Jurgens Center officially joined the Asante Consortium in 2006, and our initial involvement was really just bringing Kenyan medical students over to Duke for 6-week experiences of their medical school training. And that was the only involvement that we could come up with at the time. The ideal of the consortium is that a different institution will take on a leadership role to anchor a clinical therapeutic area. And it was pretty clear that they didn't need our help in HIV because they already had an extensive platform on the ground there. And our infectious disease docs were already too booked doing their HIV work in Tanzania. So we weren't sure where we were going to fit in. Initially, it looked like we were going to get into OBGYN and women's health. Around 2007, AMPATH was making a strategic decision that that's where they needed to go. The Duke OBGYN department, primarily Jeff Wilkinson and his wife, had made a commitment to join with the University of Toronto and to move his family overseas to live there for a couple years to start up a women's health program in Eldoret. And unfortunately, just as they were getting ready to go, the election violence in 2007, January, diverted their plans, and they decided it wasn't safe for their family to go. So they ended up moving to Moshi, Tanzania, where we do have an active women's health program going on. But instead, in the OB area, the University of Toronto continued forward. And from the Duke standpoint, we weren't sure where we were going to fit in. At any rate, in 2008, as Eric mentioned, AMPATH decided to start moving into primary care and chronic diseases. And when the Cardiovascular Center of Excellence opportunity came along, we elected to participate. And so now Duke's role in Eldoret, that goes above and beyond the grant or the contract mechanism per se, is that we are the anchor institution for cardiology in Eldoret. And so that opens up a lot of opportunities for us. In 2009 is when we actually got the funding from the NIH. But as I mentioned before, Duke is still actively involved in a number of areas in Eldoret, and part of this is made possible by the elective rotations that the Hubert Jurgens Center does, but also by us developing other therapeutic platforms in Eldoret to serve as training sites for the Global Health Residency Program that we run. So right now, we just had an OB Global Health Fellow come back. She's spending her rotation in Eldoret. We've looked to expand in emergency medicine. Dr. Chuck Gerardo and Cecilia Pezdek went to make a visit there, and we hope to get further engaged in Eldoret and emergency medicine. In psychiatry, they have a very good researcher there. Kristen Shari just completed her residency. She did a rotation in Eldoret and was successful in getting a K award and hopes to go back. And also we have Tom Holland in infectious disease, who's in the Global Health Fellowship Program, and he's doing his rotation in Eldoret. So aside from cardiology, where we're really an anchor institution, we have a number of other things going on there. This is the picture of the team for the Center of Excellence. Dr. Silvestro Camayo is in the center there. Joe Mamlin, I think Eric mentioned to you before. Shamim Ali, Dr. Shamim Ali is our program manager in Eldoret. And then we have Myra Magasi, who's a peds cardiologist. She is the only cardiologist in all of Western Kenya. And then Dr. Ndege with the primary health group. So I'm going to pass back to you.
So I'm going to go very quickly now to just tell you what we're doing, and then I want to leave plenty of time for Jerry to go into his experiences and then some time for questions, so hopefully. So this is our mission statement. We establish a unique and sustainable continuous quality improvement effort and environment in Western Kenya and to cyclically evaluate how to diagnose, characterize, treat, and ultimately prevent chronic CVD. We have many partners, again, this twinning concept of Moy and Duke, but also Indiana University playing an important anchoring role, and Brown University, particularly as it relates to pulmonary support and pulmonary expertise, is playing an important role. And there's different critical components, including the DCRI, the many AMPAS centers and clinics where this clinical care and clinical research will continue, the Brown Flaherty Center, and the Moy Teaching and Referral Hospital. And these are our goals. Remember, this was funded to develop a clinical research platform to take advantage of existing infrastructure. It's something I'm going to return to because it's very important. You can't have clinical research if you don't have clinical care. And you already heard Cynthia talk to you that the only cardiologist in the entire Western Kenyan region is a pediatric cardiologist who hasn't really, she's a wonderful human being, but hasn't really pursued the kind of training that we would expect is required in the American or European systems for cardiology care. So we have to develop a clinical infrastructure to do the clinical research that we're funded to do. Our goals are to organize an administrative core for care and research, develop and implement a competency-based curriculum for clinical care, establish a clinical research training program, adopt and enhance existing data as well as other management infrastructure, and they have quite a bit on the ground, which you'll see in a moment. And then, to me, the most important and fun part of this, which we're just getting in the midst of, is to start implementing specific clinical research pilots that are very context-specific, addressing the needs of the location and the individuals who we're serving. And will be, in many ways, the laboratories for us to continue to develop the other goals. So this didn't come out very well either. I'm not sure why it's so fuzzy, but the concept here is, kind of access all these levels of expertise on the left and pair that with the infrastructure that already exists for HIV care to the expertise that we're bringing to the table and develop something new that could focus on clinical research goals in cardiovascular and chronic diseases. This is an actual building, kind of like the building we're sitting in now, relative to their campus. It's really a data center. It's their DCRI, so to speak. It doesn't seem like much, but actually to have a building focused completely on the needs of data infrastructure management is a huge investment, as well as a milestone for this group in terms of their development. And this is kind of what excited us as we started thinking about the potential of applying for this grant with them, is that they had something already available. They have some very basic cardiovascular diagnostic capacities. They have 1 or 2 echo machines. I went with Mike Foster. Dave Adams is in the audience, also helped. And we've started outfitting some basic diagnostics for clinical cardiovascular care. But, when Mike got there and Jerry was using these machines don't tape. They can take a few pictures, but we can't document any disease and we're starting to revamp what we can do there. Same as the ECG platform, very, very basic. For those of you who remember the old VA treadmill EKG strip by strip, well, that's kind of like what we're talking about here, and we've already made major strides. Conceptually, the core team is built on kind of this twinning concept where you have people on the Kenyan side and people on the Asante partnership side that are forming a partnership to push forward the goals of the Center of Excellence. And obviously there's operational leadership, there is faculty leadership, there's implementation teams, and co-field directors of research, co-field directors of clinical care. The concept of twinning, again, is important. And we have several training deliverables that we've put forth with the NIH that we need to meet. And here, the idea of developing competency-based curriculum for paraprofessionals as well as clinicians, as well as faculty in terms of basic research methodology, in terms of clinical care. The certificate is pretty much all we can give them. And it's an important milestone in their own development. And we're going to probably be asking a lot of people in this audience to help us develop those over the years as we've already gotten started. So I'm going to ask, again, just a little bit back and forth. I'm just going to just highlight a few things that we feel are different about our Center of Excellence that make it even more challenging. I want Cynthia to comment on a few operational challenges that some of the operational folks in the room might appreciate. And then we'd like to turn it over to Jerry to give us his perspective on this first year. So we are a little different than our partner Centers of Excellence because we've adopted another disease state model to build on. So they're very good at HIV. They developed this entire platform built on funding, USAID, PEPFAR funding, to build this platform to deliver HIV care and have done it very well. Well, we're kind of building on that platform to now expand into chronic diseases, which is slightly different than what our other center partners have done. We do not have clinical care on the ground in cardiovascular pulmonary disease. That's different. I mean, we really, to be very frank, we don't have any ability to provide clinical care. We're building that from the ground up, and that, I think, is an additional burden. And we can't use any of the funding that we received because the NIH funding is for clinical research, not clinical care. And that's this tension that we feel. So, Cynthia, maybe you can just comment from where you are, and I can advance the slides, perhaps.
Sure. So I think we've kind of laid the groundwork to help you appreciate that what they do have on the ground there in terms of being able to do research is really pretty remarkable compared to most developing world sites. They have a very seasoned grants and contracts office. In fact, the director of their office has recently become the PI of an NIH grant to help set up research training offices or grants and contract offices in other locations in Kenya. So that's a huge kudos in their cap. They do have an FWA-approved IRB. They've got years of HIV research. They do have some SOPs, certainly not the kind that we're used to here, but they have them. I think Eric alluded to the electronic medical record system. They do have a reference lab that's up to standards for doing research, although, again, it's still lacking a lot of the cardiovascular parameters that we might need at some point. And what we really haven't touched on here is the extensive community network. The AMPATH clinics cover a catchment area of roughly 2 million people. They're going out doing door-to-door testing in the middle of nowhere, GPSing with decision support on a Google phone. So it's very impressive, and we're getting ready to roll out hypertension screening, blood pressure screening, with that mechanism. So it's pretty impressive. In terms of some of the challenges, this grant, or this contract rather, was the first time MOI was the primary awardee on an NIH award, and that's pretty significant. It was also a bit of almost a showstopper for us when we realized that was the mechanism that NIH wanted to do, because typically what MOI has been in the position of in the past is that the U.S. partner is the primary awardee and they're the subcontractor. In this case, we're the subcontractor, and that's been a steep learning curve for MOI. Just even in terms of the restrictions on funds, them having to be the primary communicator with the sponsor, the importance of those relationships. I think it's really important that people appreciate, perhaps in the developing world more than others, although certainly this is probably true of all international types of collaborations, but we are really the guests. And the relationships come first and business second. And I can think of no better way to highlight this than when Nathan and I were recently on a trip there this summer. We had wanted to meet with the OB director in the hospital. We couldn't collaborate on a good time. He came out to the airport to meet with us as we were standing in the security line for 5 minutes to make sure that he had a chance to talk with us personally. So we just cannot overemphasize the importance of paying homage to the people that you're going to be working with and showing them appropriate respect. Cultural differences in communication style certainly is a challenge, and I think Jerry will get into some of these things a little bit more later. But they're very formal with the British system, and when you go to meetings, they will, invite you to speak or to ask questions. And so when you're trying to manage things on a conference call where Americans are very direct and straightforward and just jump in, you don't always hear from your colleagues unless you solicit their input. I think two things that I just have to mention is the issue of private practices. These folks work in the public hospitals during the day, but then they have their private practice in the evening after hours to generate income. And that can sometimes compete for their attention, and that's a challenge. And then also research as a career is a novel concept, and we're trying to develop a platform that encourages investigators to want to do this as a career, and they don't really have mentors yet where they've seen that happen. And so these are some of the things that we're trying to help establish a baseline for as we move forward. Go ahead. Yeah, these are obvious, and I think Jerry will talk about these a little bit more. I just wanted to address this one last thing. I don't think anyone can really fully appreciate the resource constraints until you go there, even though you hear about it. And certainly the research can't come at the expense of clinical care. And just to bring up a couple things, the box on the left is PAC's platform that Eric lugged with him on one of his trips to go along with our portable echo machine. But the Hubert Jurgen Center, together with the Duke Global Health Plus, which is surplus medical equipment from Duke going to developing world countries, we partnered with an organization called MedShare in Atlanta and shipped a 40-foot container of supplies in the early part of this year to help get both the OB and the cardiology program going. So with that, I'm going to turn it over to Jerry.
Let Jerry get up to speak and just kind of concentrate.
Great, thank you. So I went over to Kenya last year as part of the AMPATH Center of Excellence program. I spent 11 months on the ground. My primary project was a project looking at markers of atherosclerosis amongst patients in Western Kenya, patients with heart failure in Western Kenya. And the reason we decided to do that was that heart failure is endemic in Africa, and although it's a very prevalent condition, even today the etiologies are obscure and it's not really sure exactly what's causing all the heart failure you see there. If you read any of the textbook, it'll tell you that rheumatic diseases, hypertension, and cardiomyopathies are the most common. But in truth, the data that is based on is that hasn't been updated in the last 50 years or so. There are only 9 total epidemiologic studies between 1950 and 2007 examining the causes of heart failure in this part of the world. And the only investigations they've ever been able to do are ECG and autopsy-based, looking at atherosclerosis, which obviously are limited. So we decided to perform that study, which I spent the last year getting involved with. And I won't present anything more about this study because it's ongoing, but we thought what might be more interesting was how do we get this study off of the ground in Kenya. So briefly, the specific aims of what we were doing were to describe the causes of heart failure in this particular hospital, to look at the prevalence of atherosclerosis amongst patients with heart failure in this hospital, and lastly, to look at some modifiable and non-modifiable risk factors for atherosclerosis. So as I mentioned, I was there for 11 months working at the Moy Teaching and Referral Hospital, and when I thought about what would be good to present for a few minutes here at conference, there are so many things that I could report back, both professionally and personally, and how rewarding this experience was. But the top three questions that I get asked are, how did you work that out? Meaning, how did you get over there as a fellow? What did you do, and what are the next steps? So let me hit the highlights of those, and then take some questions. So the challenge in getting this done is that this is a novel training pathway here at Duke within cardiology. There isn't an established track record or mechanism for trainees in cardiology who are interested in global health research to do this. And so I spent the first few years of my fellowship time, along with my mentors, trying to figure out, number one, could this get done and how this would be done? And I think that was a challenge. And the solution that we eventually came up with was a diverse mentorship panel that employs university-wide collaboration. And you've already heard how the Global Health Institute and the Hubin-Jurgen Center have come together, and the Division of Cardiology and the DCRI. And myself, I draw mentors from all of those places. And we were also able to leverage novel NIH programs. The Fogarty Center has a strong track record in doing global health-related research, not so much in chronic diseases, whereas the NHLBI, who funded the Center of Excellence program, has a strong track record in chronic diseases and is starting to get interested in global health. And so I took advantage of how those two programs might mesh. And we constructed a 2-year clinical research training experience in global cardiovascular disease based on input from the Fogarty International Center, which sponsors a fellowship that's run through Brown University for the site in Kenya, the Duke Global Health Residency and Fellows Program, the Division of Cardiology, the DCRI, our COE, and the Joseph C. Greenfield Scholars Award. All of these programs came together to help create a 2-year clinical research training experience. And for trainees moving forward, I don't think we all believe that this will be applicable to every trainee. You have to apply for some of these things, but it's definitely intention of the leadership of all these different centers to create an established track for cardiology fellows and perhaps other fellows to do clinical research of this type, which in cardiology is unheard of. There's 1 or 2 places around the country where this is happening. So people ask, what did you do? And then there are usually a few. Right. It could be. People ask, what did you do? And then there are usually a few quips about what I actually spent my time there doing. But if you haven't worked in sub-Saharan Africa, some images may come to mind. But I think Cynthia and Eric have already laid the groundwork that this is not what clinical research in Kenya looks like. So the global health experience that I was able to get involved with was fun and interesting. I spent a lot of time in cardiology clinic. We did inpatient consultations for medical patients, OB patients, orthopedics. I spent time performing echocardiograms and teaching both echo and EKG to the techs and the fellows there, teaching medical students and residents, getting involved in some of the community-based education activities that AMPATH does, where you're going out to literally the bush and doing some amazing things. There are IT people on the ground who are very versed and good at what they do, but the numbers are small, and so remotely I had to learn some IT issues, so I came out of my comfort zone a little bit. Well, probably the most important thing about spending time on the ground, and I think you've gotten that from what Eric and Cynthia have spoken about already, is that if you're not there face-to-face, you can't expect the program to survive, and you can't expect your partners, and in this case our Kenyan partners, to really take you seriously. So implementing a research protocol there in heart failure, there were many challenges that came along the way and many lessons, and I'll just touch on some of these briefly. For whatever reason, when we, Duke, came to Eldoret, there was a perception that we had that we may be there just for research, quote unquote. And I'm not sure where that came from, but we overcame that. The lessons we learned were that by sitting down with our colleagues and just making sure every voice was heard and hearing some of the concerns that people had when we're starting a program that's funded to do primarily clinical research and training and not funded to do clinical care. And there's a Kiswahili word called harambe, which is just the act of pulling together, that once everyone's on board and we all own this project, then we all work together to make it happen. Equity for study participants is important. You've heard that the ANPATH program leads with care, and that's primarily what they're there to do. And so whenever we're enrolling a study patient, if it's at all possible for them to benefit directly from interaction with the expertise that we bring to the table, we make that happen. Top-down management is an important one, and here, it's important to take the initiative, and it's important to troubleshoot and look ahead and forecast and take problems off of your colleagues' plates if you can. But that doesn't always go over well when there's a very top-down management style, and so the lesson there was just keeping everyone up to date with what you're doing. And not to do that by email. The email etiquette is also very different. Email, even with some of our colleagues who are on our grant, weren't checking email even on a weekly basis when this all started. And so we learned that, again, being there face-to-face is a lot better. Different concepts of time are also a challenge that we had to overcome. If you were sitting in a meeting that was scheduled to go from 1 to 2 p.m., the first 15 or 20 minutes could easily be taken up with just greeting everyone and hearing how everyone's doing, and not sort of the how was your day, but really hearing how someone's is going on with their life, their family, their personal life. And so it may be 1:30 by the time the agenda is getting started, and you're getting antsy, saying, well, I'll never get to my agenda items. But the correlate to the first point is that the end time for these meetings is also organic, and meetings don't usually end until everyone has had their say. And if that's at 2 p.m. or 6 p.m., we're all done once we're all done. So in the meantime, just sit back and enjoy the chai or enjoy the tea. I've already mentioned how important it is to be there on the ground. Moving through the IRB, it's not an electronic process like eIRB is, and so you're literally moving papers from one office to another office and getting signatures. And again, if you're not there face-to-face, that can become challenging. And lastly, in training our support staff, we had to do a lot of our training remotely or through people who were on the ground but who weren't trained to train research assistants like myself. So again, just stepping out of your comfort zone and being willing to do things that perhaps you haven't been trained to do. But all those things being said, we do have significant achievements within the research realm. We've gotten IRB approval for our study. We've gotten approval from 3 IRBs, twice each. We can talk more about that later. And 2 sponsors. We've brought equipment on site, as we've heard. We've established an IT infrastructure where we can now view echoes that are performed there on site. We can view them remotely using the internet. We have local buy-in and leadership. Our heart failure study took a while to get approved, but we've started enrollment as of May 2010 and already have about 40 patients enrolled. And we've established regular, frequent, and meaningful communication platform. And these achievements are within the research realm, and this is not to mention the tremendous benefits of the relationships that were built, the clinical experience as a cardiology trainee, the teaching opportunities, and my own personal education. So we'll end here, and the question people ask, usually it's what's next, and I think both Eric, Cynthia, and myself, we hope that at the end of all this, we hope that you are part of this to some degree. There's a tremendous opportunity with the Center of Excellence in Eldoret, Kenya. There's NIH funding behind this and partners who are very enthused about it. Regarding cardiology trainees or trainees in other disciplines, there aren't many of us out there. And myself and another fellow from Northwestern, we put together a paper that we published earlier this year talking about perspectives, challenges, and opportunities that fellows interested in global chronic disease research may want to be aware of. And I've just put here the table we put in, which outlines some funding sources, again, as you try to craft a research experience that may not have an established track record, and general information about global chronic disease research.
So if there's time, maybe for a minute, we have a Q&A session. Well, we've got
to the group for very impressive work. It's laudable. It's obviously very meaningful and has high clinical relevance in terms of global health. I don't know how you've done all the things that you've done other than with passion, which is clear. So, a comment or question? We do have at least 2 minutes.
Could you give us a better sense of what the distribution of available Kenyan personnel is on the ground? I mean, you mentioned medical students. Is there a medical school there? How many trainees that are native are engaged in this? And I presume from what you said that with Moy being primary, that this is not about sending Americans over to get a global experience, but more training the people. But I don't know that for sure.
I think it's like everything. It might be a team answer, but there is a medical school. It's, again, the second medical school in the country. And there are different types of trainees across the teaching and referral hospital, from medical students through registrar of residence types to, and there's no true fellow experience. What we've built is actually a fellowship program in cardiovascular and pulmonary disease, and actually we are just through our second enrollment, and we actually had a competitive enrollment that went across the whole Kenyan country that was really run, I think, very well by the Kenyans this year. We did the first one that were kind of hand-chosen, last year's 2-year fellows, and now we have a new group starting. Most of their time will be there focused on a clinical research project, which is really what the NIH, it's hard to kind of remind them, but it's what they're being funded to do. What we haven't really, we're still struggling with is how to integrate an appropriate amount of clinical training so they can be the leaders in clinical research in cardiology and pulmonary disease for the future. And that's, I think, the challenge that I feel very astutely, because we haven't really developed a mechanism to fund them to get additional training which they can't get there.
Can I just want to say one thing. I know we only have a minute, but the Clinical Trials Transformation Initiative is focused in the U.S. on how to make clinical trials less burdensome and less complex, so we can answer more questions. We have some members from, I've told Eric this, from the University of Oxford that are involved in trials in developing countries and are working with communities to actually have the local people come up with solutions that work, that are not our typical way of dealing with things. And the last thing we want to do is sort of reproduce our SOP approach to these countries. So I would welcome connecting, I've mentioned this to Eric, welcome connecting you to our colleagues at the Center for Global Development and also the University of Oxford's Global Health Program that we're working with to do that specifically, because it is focused on research operational techniques that might be more applicable in that environment.
Yeah, I just wanted to mention 2 things we are doing. The emphasis for the Kenyan trainees really is on developing clinical investigators. And so they've already gone through their residency training, the 2 folks that we have now and the 2 new ones that we brought in. One of the things we've done is, if you're familiar with Bill Wilkinson's clinical research training program, he's been gracious enough to modify that for our global health folks. And so our 2 people last year, in addition to some other people globally, received about 20 to 30 modules of individually mentored clinical research training remotely through distance learning. And we've been really impressed with how well that's gone. From the clinical standpoint, as Eric mentioned, we actually have a cardiologist that's going to be on the ground beginning in October, a former Duke resident, I believe, at one point, John Lawrence, and he's retiring from practice at Asheville and is going to be living overseas for 2 years, about 8 months out of the year. So that said, we're still able to also train biostatisticians. We're training MPH students over there. So it's really to develop a broad platform, but the emphasis is clearly on the Kenyans.
Yeah, and I think the other thing to state is that the trainees do not necessarily have to come through a Duke relationship, because this is a multi-institutional partnership. For example, Brown really is taking the leadership so far, and I'm hoping to get engaged the Duke folks as well in terms of biostatistical, biological training with a guy named Joe Hogan, who's great. And he has actually trained PhD students, Kenyan PhD students, to go back and help, kind of ferment the clinical research platform there. So there's a lot of work to do. I guess just to highlight, the clinical arena is what concerns me the most, because I think we're ended up a lot of the excitement for the trainees is, they want to be a specialist where specialists have never existed, to be able to approach disease states that have been ignored. Now, you don't have to be a specialist to treat hypertension or coronary disease. Primary care physicians do that all the time, and we want them to be the leading edge to train the entire platform of clinicians in Kenya, and we're having challenges coordinating clinical training in terms of kind of basics of cardiovascular and pulmonary disease, subspecialty training, just because of what you can imagine. Residencies don't translate across international lines, and so that's a challenge for the next few years, I think.